Morning, I'm Dr. Phil Schauer at the Cleveland Clinic, and on behalf of co-director Steve Wexner and Adrian Park, I'd like to welcome you to this edition of Innovations in Surgery. This morning we have a fantastic program that will be presented by my colleague Dr. John Rodriguez, but first let me welcome our attendees for this morning. We have today participating will be Anne Arundel Medical Center, Cleveland Clinic, Weston. We have Dalhousie University in Nova Scotia, Canada, Duke University, Florida Hospital, Geisinger Clinic, Indiana University Hospital, IRCAD in Strasbourg, France, Johns Hopkins, Lacanau Hospital in Pennsylvania, Mount Sinai in New York, Mount Sinai Beth Israel, NYU Winthrop Hospital, Stony Brook Hospital, and The Ohio State University. Well, this morning's presentation I think you'll find very interesting. Dr. John Rodriguez is my colleague here at the Cleveland Clinic. He's an upcoming star, and he's going to be talking to you about gastroparesis, time for an update, and he'll be featuring a new technique called POP, which is per-oral pyloromyotomy, which is a fascinating technique that he'll describe. So take it away, John.
Thanks, Phil. So first of all, thank you for the real honor of being here once again, talking about a very controversial topic, because for those of us that deal with patients with gastroparesis, I don't think any of us are really big fans. So I'm going to try to make this as interactive as possible, because I would love to get opinions on everybody that's logged in today. I have no financial disclosure, and my first real disclosure about gastroparesis is that in my mind it's not really a surgical disease. It's been managed that way for a long time, but I think tackling as a surgeon is a very challenging topic. And I just want to read a few lines from an editorial that was published in Gastroenterology a few years ago by Professor John Tak from Belgium, who's done a lot of research in this topic. And he's talking about how routine investigations fail to identify biochemical or organic abnormalities in symptoms for patients that are presented with different gastrointestinal function problems. And he finishes his editorial saying that these so-called functional gastrointestinal disorders are highly prevalent, they're poorly understood, and they have major individual healthcare and socioeconomic impacts. And for those of us that treat these patients, we could not agree more. So a little bit of background: it's one of the two most common sensory motor disorders of the GI tract. It's 4 times more common in females. And the definition is very simple. It pretty much consists of symptoms of delayed gastric emptying, mainly nausea, vomiting, pain, early satiety, in the absence of any proof of a mechanical gastric outlet obstruction. And when we evaluate these patients, we have to be able to prove that there's some objective delay in gastric emptying. The etiology is highly variable, but the most common causes of gastroparesis in modern practice are idiopathic about half of the time, diabetics, mainly type 1 diabetics, post-surgical, either from vagal nerve injuries or other foregut operations, and viral gastroparesis. It's really not that simple. I mean, I think we can all agree that there's a very high incidence of chronic pain and narcotic dependence in this patient population, which makes it very challenging. In diabetics, it's usually associated with very poorly controlled diabetes. There's a lot of coexistent complex comorbidities, and these patients come and see us with very high expectations looking for a cure. And as a chronic condition, we can't really offer patients a cure because I don't think there's one. But looking at it from a public health care, it is a real problem. There's about 6 million people in the U.S. alone that's been affected by gastroparesis, and that's about 1.8% of the population. Looking at diabetics, about 14% of type 1s and almost 10% of type 2 diabetics will develop gastroparesis at some point during their disease process. And when you look at a cohort of patients that are diagnosed with gastroparesis and their peers, the 5-year survival rate is significantly decreased, looking at 67% versus 81%. So clearly, this is really affecting our population in a marked way. It has also grown quite significantly over the past 30 years. When you look at admissions for gastroparesis in the late 1990s, near to 4,000 patients were discharged with this diagnosis. A few years ago, we're looking at 16,000 patients, and the aggregate charges related to this disease have increased about 1,000%. So I want to break here for a little bit, and maybe I want to go around.
Sure, yeah. Yeah, so I guess the question we want to throw out, John, to our group is, how do they manage gastroparesis from a surgical point of view? That's what you'd like to ask, right?
Yeah, I think right now, how are different hospitals approaching these patients? Are they coming in to see surgeons, gastroenterologists, being referred? I think that's kind of the biggest question out there.
Okay, all right. So let's hear what our group has to say about this. Let's first go, because it begins with an A, Anna Rundle, and I see my good friend Adrian Park there. I know, Adrian, you guys must have some incredible expertise in these four gut problems. You have instant cures. So tell us how you guys approach gastroparesis.
Well, you can imagine, you can imagine that it's not kind of one monolithic approach to gastroparesis. And Alex Gans isn't here, and he may have a comment on the bariatric population, but for the foregut population that I deal with, it's as was presented, it's a complex etiology. There's not a lot of those patients are necessarily narcotic, dependent, and not a lot of them are diabetic. There's other etiologies, and so one of the things I will say is that with some of the large paraesophageal hiatal hernias, you find that when they've been intrathoracic for a very long time and you return into the abdomen, a different physiologic environment, they often come back and are hypomotile for a long time. And it used to be we would do emptying studies before surgery, and would often do emptying procedures at the time of the rest of the reconstruction. And I stopped doing that a long time ago, because what we found was that when the stomach, when you bring the stomach down, and sometimes you're adding a gastroplasty, so removing a small volume of the stomach or creating a fundoplasty, the emptying of the stomach improves. The actual mechanics of emptying are assisted somewhat, and that combined with dietary therapy, and we really focus on dietary therapy, how, when, how much our patients eat, reduced the rate at which we did emptying procedures just dramatically. So we do a lot of that. Alex, I don't know if you do anything different.
Yes, good morning. I do bariatric surgery, so gastroparesis is a very important topic for us, specifically to be diagnosed before deciding what's the best procedure for the patient. Sometimes those symptoms are very subtle, and we're very keen on trying to identify them before surgery when it comes to offer a gastric bypass versus a sleeve gastrectomy. There's a lot of studies that suggest that sleeve gastrectomy may improve gastroparesis in certain patients, but then again, I found certain patients that following gastric sleeve, the sleeve doesn't work as well. So brings the conundrum, what's next? Should we continue this medically or offer them another surgical alternative?
Very good. And John, and you do bariatric surgery as well. Your thoughts on the patient with gastroparesis and bariatric problems?
Yeah, I mean, I agree. I think it's a very challenging decision making, because I do prefer doing a bypass for these patients, but I've seen a good population come back with persistent symptoms even a few months after surgery. And I guess the big question, which we're actually studying right now, is what to do with the remnant. Are they getting symptoms because the remnant is still getting distended, which is very difficult to prove? So should you take it out? Should you do a near total gastrectomy at the time? And in those with sleeves, which there's growing evidence that it's a good operation, and we've had very good results, we're finding the same dilemma. So they come back, they're having, most patients describe it as reflux, but it's really not reflux, it's a very poorly emptying sleeve. Let me share kind of how we've evolved here in terms of tackling this difficult patient population. So the first thing I'm going to say is that to be able to accommodate these patients, you have to really set up for success. And I think as surgeons, we have to understand that we need a multidisciplinary team where we're really a very small component of it. So I think my number one credit in how we've evolved here has been to our gastroenterologist, mainly Dr. Michael Klein, who's really took the leading role in this for our gastroparesis center. And we recruited a couple of different people, so a clinical psychologist, a pain rehabilitation specialist, endocrinologists that are interested in diabetics with gastroparesis, a nutritionist, which I cannot underestimate the role of a nutritionist, and ultimately us as surgeons helping a well-selected population. This has really dramatically improved our outcomes. In terms of the evaluation, and I'm going to try to move very quickly through this, in my mind there's three main principles when we evaluate these patients. Number one, understand the anatomy, make sure it's really a functional problem, make sure it's not a mechanical problem, which we see quite a bit after foregut operations, mainly with endoscopy, imaging, whether it's in the form of upper GI or a CT scan, and chart review, especially those patients who are coming with previous operations. Make sure you review those operative reports. Evaluation for GI motility, I think, is the most complex of all, so good history taking, gastric emptying studies, which I will elaborate a little bit on, and most recently capsule studies. And the nutritional status is key. A good physical exam and basic lab work will give you a good sense of what the nutritional status of the patient is. So again, with anatomy, endoscopy and imaging studies are key. In terms of GI motility, I think the gold standard for most of us is a gastric emptying study, which is widely available. Unfortunately, the protocols are not standardized, and not everybody has the same approach to medication, so the results can be widely variable. But I like to keep our protocol into a solid meal, mainly with egg whites, and imaging immediately at the 1, 2, and 4 hour mark. So our scintigraphic curves look something like this, and it gives you a really good idea of what your emptying is 4 hours after the ingestion of the meal. Now, I'm going to elaborate a little bit more on this because it's kind of a newer kid on the block, and it's been really one of the things that has changed our practice quite dramatically, and it's the use of wireless motility capsule. For those of you that are not familiar with the wireless motility capsule, it's a small pill that has a pH sensor, a pressure sensor, and a temperature sensor, and basically measures those three things to give us information about how the GI tract is working. And the data that comes out of a smart pill test looks something like this. And if you look at this chart, which can be very confusing, in green we're showing pH, and in red we're showing pressure. And basically when you look at this data, looking at how the pressure and the pH change, you can infer with very good precision where the pill is at, and calculate different transit times for the stomach, the small bowel, and the colon separately. So the interpretation that comes out of a test like this gives us a couple of different numbers, and I think it's key in interpreting how this is affecting our patients. So gastric emptying times, small bowel transit time, colonic transit time, small bowel and large bowel transit times, which can sometimes be abnormal even with normal ranges for each one individually, and the whole gut transit time, which is also a key player here. And what we've learned by doing these smart pills on our patients, and this is data that we presented a few years ago, looking at the first 500 smart pills, is that a lot of patients that were labeled as gastroparetics because their main symptoms were nausea and vomiting, only about 26% of them had isolated gastroparesis, and about a quarter of them had a generalized delay. So I think when I first look at this data, I think it explained to me why our outcomes were not as great as we would like them to, and I think the key is that we were not selecting patients well for different surgical procedures. So the take-home point from this is that the incidence of generalized delay in this patient population is extremely high. So we're looking about a third of the patients that are coming in with a diagnosis of gastroparesis really have a generalized delay of their gut. And again, so looking at how motility works is key because it will predict how your surgical outcomes are. So So, and I tell this patients all the time, I think the best way to think about this is that motility of the GI tract is really no different than plumbing in a 3-story house. And if you have a slow toilet up in your 3rd floor, but the problem is a root from your neighbor's tree growing into your main sewer line in your basement, it doesn't matter how much you plunge it or how much drain you put in it, it's just not going to work. So, given this, I want to move on to surgical therapy, but I would love to hear if anybody else has had some experience with Smart Pill or how they're evaluating their patients for gastroparesis.
So regarding evaluation, well, let's go to our colleagues at Johns Hopkins. I think I saw Mike Moran there. The question is regarding evaluation for gastroparesis. Hey, Mike. Good morning. How are you?
Good morning. I'm just going to make a couple comments. Dr. Dralis is here, who's really got a special interest in this, but I would just emphasize, I like your point that this is not a surgical disease, the majority of them, and that having a team is critical. Several years ago, we put together a multidisciplinary team that is key, and one of the key pieces is that you can't get to surgery unless you've already been through that multidisciplinary team. The other thing I would just say in terms of evaluations that our group has added, the multidisciplinary team piece, is a very, very elaborate 4-day nuclear medicine pan-GI motility study. Patients hate it because they have to come back 4 days in a row, but it really helps risk stratify. One of the key points you've said is that this is not one size fits all. You really need to characterize the nature of the patients, the diabetics, the PEH patients that Adrian talked about, the bariatric patients, and really start to come with a coordinated multidisciplinary team approach. But with that, I'll turn it over to Dr. Dralis.
Thank you, Mike. We are not using the Smart Pill right now, but we're in discussion actually with them for evaluation for this, as well as in some of our bariatric patients. I would agree with Mike about the multidisciplinary team and the need for that. The other group, not just with gastroenterology, but we're working as well with a multidisciplinary dysautonomia group, because so many of our patients, as Mike alluded to, have other issues. A lot of them have cardiac dysautonomia and other things that need to be addressed, which is very much outside in some ways of surgical care, but can affect their post-operative management greatly.
And I guess just one last comment that you alluded to at the beginning of your talk, which is probably critical with all these patients, is expectation management. The lower right of one of your early slides, you said high expectations, expectation of cure. It's not going to happen, and they need to understand that early on.
Yeah, those are all good points, John.
Yeah.
With respect to what Mike brought up about the motility studies, the foregut and mid and hindgut, is that something that you guys do routinely in all these patients, or very selectively?
So we've been going back and forth, for the past few years, and we used to do a very similar nuclear medicine protocol, and I think they pointed out some of the weaknesses, which is patient compliance, and this is a patient population that is well known for not being compliant. Also, we have a very large population from out of town, so sometimes from a financial standpoint, it's really difficult to get them to stay here for 4 days and things like that. So when we started doing Smart Pill, and we've had to jump through a bunch of hoops because it's not universally covered by insurance, and I think that's the biggest thing, and it's a fairly expensive test. We've been working hard and appealing insurance denials and things like that, and so far we've done a little over 1,000 Smart Pills, and the data has been really great, and it's really changed our practice. So now if we can, we'll do Smart Pill testing, and we've kind of moved away from some of the other radiologic tests. The one that we still do quite a bit is SIDS markers for chronic inertia. Our colorectal colleagues like it quite a bit, but it looks mostly at the colon.
Okay, very good. Well, John, tell us, what can surgeons do? What can surgeons do for this disease? And maybe you can tell us the rest of your talk.
Sure. All right, so now comes the fun part. So talking a little bit about surgical therapy, I like to think about this in 4 main groups. Surgeries that that we do for symptom improvement, and those are things like the gastric electrical stimulator, gastric emptying procedures, and bariatrics or gastrectomy in some patients. And a different subgroup of enteral access. I think it's key to understand, especially in diabetics and severely malnourished patients, that enteral access, even though I call it the necessary evil, it's sometimes needed, and you need to do it to get these patients through their nutritional struggles. So I'm going to start talking a little bit about gastric electrical stimulation because it's been around for quite some time, since the first papers in the early 2000s. And among patients, it's a very popular operation. They come asking for it. In my experience and with our group, it's fallen out of favor quite significantly because it's not really the panacea, I think, that we believed it was going to be at some point. So I think the take-home points for gastric electrical stimulation, and there's a lot of data out there on it, is that patient selection is key, and different subgroups really benefit differently. So in diabetic patients, the data is very compelling about symptom improvement, much more than idiopathic or post-surgical. So in our practice here, we offer gastric electrical stimulation as part of the surgical therapy. It's falling out of being a first-line therapy, but we still consider it mainly in diabetics, sometimes idiopathics that have failed other approaches. So the reason that we moved away from this, and it kind of drives me a little bit crazy when you go back and look at why we do things. And I asked myself, why do we do this as a first-line therapy? There's really not a lot of good quality data supporting the efficacy of it. There's a couple of randomized controlled trials, and really no one has been able to prove that it improves gastric emptying. And the long-term complications are real. When you look at patients that get these operations done, I think that the risk of them having problems related to the pacer over a 5 or 10 year period is fairly high. And some of those complications can be very minor, but some are really, they really put a big toll on their quality of life. We see lead erosions, we see generators flipping, lead fractures, they can get infected. And one that I've been seeing quite a bit for the past 4 or 5 years is a shocking sensation. And these patients really are annoyed by the pacer, and they don't feel like it's helping their symptoms. So we end up taking a lot more pacers now than we used to put in. So gastric emptying procedures has really caught my attention over the past few years, and even though they're operations that we've been doing for many years for different reasons, I think the evidence focused on gastroparetics has dramatically increased over the past few years. There's a lot of data that supports improvement in gastric emptying, which none of the data for gastric stimulators does. And I think in this day and age, it should be accepted as a first-line treatment. So one of the more compelling papers came out of Lee Swanstrom's group, looking at over 150 patients over a 5-year period who had laparoscopic pyloroplasties for refractory gastroparesis. And what they found is that the vast majority of these patients had a significant improvement in their gastric emptying time. So when we looked at this and looking at our own experience here in some other centers around the country, we kind of took a step back and changed a little bit our algorithm for treating patients with gastroparesis. And over the past few years, we've kind of moved into what I like to think about the evolution, and this picture kind of shows a little bit of the evolution. This is one of my partners, Kevin O'Hyatt, which I think is a little bit earlier in the evolution track than I am, but our fellow is really the most evolved as of now. And we looked at how to do this in a less invasive way, and we cannot claim that we were pioneers in this, but I think the way that we adopted it and how we made it fit into our patient population has made us very successful at doing this endoscopically. So over the past year or so, we've been offering per-oral pyloromyotomy as the first-line treatment for medical refractory gastroparesis. And most of the descriptions out there of this technique have been done in a greater curve approach. And we started doing it that way, but after a few cases, we noticed that, in trying different things, we noticed that going in the lesser curve really made a lot more sense, and it made this operation technically much more simple, much more straightforward. So that's our go-to technique. And I'm just going to show a video of what the 5 steps of the lesser curve approach for per-oral pylori myotomy is. So as you can see in this video, we're going about anywhere between 3 and 5 centimeters proximal to the pylorus along the greater curve. And this first step is a little bit challenging because a lot of these patients have very J-shaped stomachs and they can be very distended. But we try to get a nice bleb with an injection using methylene blue diluted in different concentrations. We initially used to make longitudinal incisions, which is what we do for POEM, but we noticed that doing a transverse incision was much easier in terms of getting into the tunnel. We use an electrosurgical knife with an Irby generator with a mix of cut and coax current. Try to get into that tunnel. This is that pushing down, I like to call it the Ponsky maneuver because he really likes to do that. It's kind of grabbing the knife and pushing that mucosa down. And once you get those first fibers in the submucosa, it really helps with a beveled silicone cap to get into that short tunnel and start taking some of the areolar tissue. So I think this first step of getting in the tunnel is a little bit more challenging with this technique, but once you're in, the rest of the dissection is really straightforward. So the methylene blue helps because the muscle doesn't stain and the mucosa doesn't stain, so it really tells you where to go in terms of that submucosal plane being dark and blue, so you kind of keep your bearings as you're doing this, because even though this tunnel is short, it's very easy to get lost. And as you can see here, we're staying close to the muscle and really taking that, trying to expose that pylorus. We don't like to go past the pylorus because the mucosa becomes very perpendicular in the duodenal bulb, so when we started doing that, we noticed that the risk of perforating the mucosa was much higher. And as you can see here, once we identified the pylorus using spray current, we proceed to just divide the fibers of the pylorus. And it can be done very precisely. It's a very elegant way of doing it, and patients like it because they're not dealing with incisions. The post-surgical pain is significantly decreased, and the recovery is much quicker. So as you can see here, we're dividing the pyloric fibers with the Irby knife. One of the challenges when you do this, because you're working in such a tight space, is that the lens tends to fog quite a bit. So we like to use a warm bottle of irrigation, and that helps a little bit with the fogging. But still, it's one of the most annoying things as we do these procedures. And it's key really to see this because the distance between getting a complete pyloric division and a full thickness perforation is really very, very small. So as you can see here, once the pylorus is completely divided, you get that kind of change in the tissue. And, we call that dividing the calamari, and then looking at that kind of blue hue in the background. And we like to take our time and really do this meticulously, even though the stomach is a more robust organ than the esophagus in terms of these endoluminal procedures. And once we're done with the division of the pylorus, we check for hemostasis, and we're using clips to close the mucosotomy, but many different things can be used. It's a good opportunity to practice endoscopic suturing as well, but clips have worked very well for us. So we presented our data for the first 47 patients, and what we saw is that these patients were really getting better, and we measured this by doing 2 different things. So we used the Gastroparesis Cardinal Symptom Index score, as well as gastric emptying studies pre-op and at the 3-month mark. And what we noticed is that these patients were having a significant improvement in their Gastroparesis Cardinal Symptom Index, mainly their nausea and vomiting scores, as well as their postprandial fullness. And a lot of these patients were coming off their antiemetic, so they were very satisfied. But again, it goes back to the point of having a conversation about what realistic expectations are for this disease. It was very challenging to get all of our patients to come back for gastric emptying studies, but for those that had it, we noticed a significant improvement, and about half of them came back with normal gastric emptying studies. Now, up to date, we've done about 118 cases, and what we've seen is about a 78% significant improvement in our gastric emptying studies at 3 months, a significant improvement in our gastroparesis cardinal symptom index, and really very low morbidity for this procedure. We haven't had any perforations. We've had a couple of GI bleeds that we had to rescope, and they both had ulcers at the mucosotomy site a few weeks after the procedure. So we started putting all patients on high-dose PPI and Carafate prophylactically for a month. We did have one death in the perioperative period, a patient that died of a cardiac, he had a cardiac event. So I think that was just an eye-opener of how sick sometimes these patients are, and we have to be very careful as part of our workup. Now moving forward a little bit, bariatric surgery I think is the ideal approach in morbidly obese patients, especially those who are diabetics, because it's almost a one-stop shop for all. It addresses that glycemic control. A lot of these patients have other significant weight-related comorbidities, whether it's hypertension, obstructive sleep apnea, so you're really focusing on the patient and not just the isolated disease. So far, the data has been more compelling for gastric bypass, and it's the preferred approach. I still think there's a question to be answered about what to do with the remnant. Like I've said, we've had to go back a few times in patients that were at least 6 months out from a gastric bypass and take out the remnant because they're having severe debilitating symptoms with really no other mechanical explanation. And what we've seen is about 2/3 of them do get better. There's fewer reports of sleeve gastrectomy, but it's gaining popularity. I think as we discover in these patients that there's clearly more than just isolated gastroparesis, and sometimes we can't really prove that, I am very careful about doing a gastric bypass in a patient where I suspect that there may be small bowel dysmotility, because these patients really get worse after you do a gastric bypass and you hook up a rulim of dysfunctional small bowel. Now, I think we all know there are significant barriers to access, whether it's insurance related or patient related. I think if you put gastroparetic patients to a very strict preoperative evaluation protocol, about 2/3 of them will have significant psychiatric illnesses that will be considered a contraindication for bariatric surgery. So I think really going back to the multidisciplinary approach, these are patients that have to be discussed in that setting to be able to kind of be more flexible with approval. I'm just going to talk a little bit about enteral access. So I think nutritional support in these patients is key, especially those that are diabetics. It's a good way to break that vicious cycle of patients that have poorly controlled diabetes. They can't really eat, so you can't be aggressive about insulin therapy. So in those patients, putting a temporary feeding tube in can really make a huge difference in terms of their symptoms. They can also be used for decompression in very severe cases, but it's very important to understand the underlying GI motility. So I will not put a surgical tube in a patient that has not proven to me that they can tolerate tube feed. So most of the time, if I don't have any objective measurement of their motility, I will put a temporary nasojejunal tube in, give them at least a few weeks, and if they can tolerate tube feeds at goal rate, then I will go back and do a laparoscopic jejunostomy tube. So I've always been told that a good talk ends up with 3 take-home points, and I think my take-home points for this talks are that gastroparesis is very challenging, so I suggest that as surgeons, don't tackle it on your own. Build up a team, make sure you have a gastroenterologist that wants to take a lead with this, and like some of my colleagues from Hopkins mentioned, and I mentioned earlier, it's really a big team that comes together to understand the disease and try to help patients obtain realistic expectations and improve their quality of life. Try to understand the underlying motility as best as you can. I know that there's a huge challenge in terms of getting these tests to look at global motility, but sometimes just putting a tube in for a few weeks and see how they tolerate can give you a great insight of what their bowel is doing. And really, this is one of those disease processes where it's not a one-size-fits-all for patients. So we will see patients that will benefit from certain procedures more than others. I think the big change in my practice with per-oral pyloromyotomy is that I've been a little bit more prone to do these procedures on patients that I would have otherwise not operated on before, and I'm not sure if that's right or wrong. I think we're in the process of finding out, but really you have to see patients individually and try to come up with what the best surgical therapy is going to be for them. Thank you very much.
Great. Well, John, that was fantastic. And if you will, I think there might be a fourth take-home message. And that is, I think this per-oral pyloroplasty is a phenomenal, promising new procedure that surgeons may be able to take up that can really help our patients. So I'm anxious to hear what our audience has to say about the POP procedure. So let's go to our colleagues at Florida Hospital. And I see that they have a very engaged audience there. And I don't know if Dr. Eubanks is there or not, but one of his colleagues could perhaps speak up about comments about this promising procedure. Good morning.
This is Scott Bloom. I'm the program director here for the residency program. Thank you for a wonderful talk. That is a very innovative approach. Certainly it's going to spur a lot of conversation here. As I'm sure you're aware, with our colleagues in the Center for Interventional Endoscopy, we have some very, Rob Hawes and his crew are very advanced in terms of endoscopic procedures. I'm sure they're going to love us invading their space to do this procedure on our own. After that video you made it look so easy, I think I'm going to try one this afternoon. Just a quick question for you. Obviously, with this, you do need to be somewhat selective in your patient population, I would think. I think you alluded to it earlier. If they don't have a good functioning small bowel, then this probably isn't going to be as successful. But have you identified an actual patient population that does better, or is it too early to say?
So that's a very good question, and I think what we're seeing with our early data is very similar to any other surgical procedure. So usually patients that are diabetics, that are well controlled, are the ones that do the best. Idiopathics, it's kind of hit or miss, because I think we still, they may have underlying low motility, and they tend to be less compliant with diet and medication, so that's really a challenge. But I think one of the patient populations that I've been very aggressive about doing this is the post-surgical. You know, I see a lot of patients that have vagal nerve injuries after foregut surgery, and you know, pacers don't work for those patients in my experience, and going back in there and doing something either laparoscopically or something like that, you know, I always see this as a first approach, and those patients have responded pretty well. I think I've saved myself from a few nightmares of having to go back in there and, you know, look at these third-time redo paras and take them down and do near total gastrectomies. So it's changed my practice in that sense. Also, patients with global dysmotility who have very prominent gastric-driven symptoms like nausea and vomiting, I used to not operate on these people, and now we're doing POPs on them and looking at how they're doing. They're actually getting some significant improvement in some of their symptoms, mainly the nausea and the vomiting, not so much the pain or the bloating, because that could be, you know, highly variable, but I think if you set the expectations right, they're going to be more prone to trying this than anything else.
That's a good point. I'm just curious, for the folks at the Florida Hospital, are any of you folks doing just standard pyloroplasties or, you know, laparoscopic pyloroplasties? And to that end, John, I'm also curious, you know, if you could tell us what the advantages are, perhaps, of the POP versus a standard pyloroplasty.
Sure. I think that we've, I don't know that any one of our group has been taking the lead in terms of doing the laparoscopic pyloroplasties. Again, we've got a very robust group with Rob Hawes and interventional endoscopy. I'm not sure if any of the other attendings are here to speak to it. Enrique, do you know?
Not necessarily, no, I haven't been able to.
No, I'm sorry, our experience is relatively limited in terms of managing it. To be honest with you, I always cringe a little bit when we hear a consult for this and find out which of my partners is on tomorrow.
So John, you showed us at least one some data, which is also impressive with the standard laparoscopic approach. So what are there any particular advantages, or is this mainly just a less invasive approach to do a pyloroplasty?
It is, and I still do quite a bit of laparoscopic pyloroplasties. I think, you know, in my algorithm right now, if I have a patient that needs a feeding tube, I'll go in and do a laparoscopic J tube and do a pyloroplasty at the same time. We actually just submitted an abstract to SAGES looking at pyloroplasty versus POP. I said POPs, and what we saw is that the results were very similar, but the morbidity rate on the pyloroplasty group was a little bit higher. We did have one leak in our series, which was about 100 and something cases for laparoscopic pyloroplasties with one leak, and that's a pretty devastating complication. We haven't seen any with POPs yet.
So you've not seen any leaks with the POP? Yeah. Have you seen any hematomas, big hematomas?
We haven't either. Yeah.
Wow, very good. Well, let's hear from a couple others before we actually close here. How about just going to Stony Brook? And I thought I saw my good friend Rory Pryor there earlier. Maybe she had to go to the OR. But maybe some of our other colleagues might comment from Stony Brook about this POP technique. Please go ahead.
Hi, can you hear us okay?
Yes.
This is Sal Dosmo over here at Stony Brook. Just one question. If we have some experience with POEM, what do you recommend in terms of us doing before we introduce this procedure at our own institution? Do you recommend some survival models first, or what's your experience moving from POEM over to POP?
From a technical standpoint, it's very challenging to replicate. So when we were training for POEM, we used the pig model, and it was a very good way to practice and get the things down. We've tried to do the same thing for POPs, and it's very challenging to do because the pig stomach is so big that we've had to sleeve it before trying to do a POP, and the mucosa is very, very thick, so it's very challenging. I got to tell you, looking at how we've evolved with this procedure and moving from the greater curve technique to the lesser curve technique, for those of you who have experience with POEM, this is really a walk in the park. And I think watching a few and maybe getting proctored through the first couple may just be the way to go if you already have the technique for POEM, because it's very difficult to replicate in an animal model. We've tried to do it, but I don't think that the trainees have really gained anything from it, because it's always like this huge hassle to do it properly, because the pig stomach is just so thick and so challenging.
Do you have any preference for the closure in terms of clips versus overstitch?
Yeah, so I've done it both ways. I think with our current technique with the transmucosotomy, usually all I need is three quick clips to close it. So I've been using clips for the past 80 plus cases.
Great, thank you.
Great, it's impressive. So you're saying this is actually a little bit easier than a POEM?
Oh, it's much easier than a POEM.
Really? Yeah. You have more space to work in, is that the...
You have more space, the stomach is a little bit more accommodating. I think for us as surgeons, the stress level of putting a hole in the stomach is significantly lower than putting a hole in the esophagus. But again, it goes back to the concept of intramural surgery. You have all you need is really a short tunnel. The gastric wall is a little bit thicker, and it's much easier to navigate the scope because you have a little bit more space.
Great. Let's hear for a couple others before we finish. Let's go to Ohio State. I think I saw Dr. Brad Needleman there earlier. And hey, Brad, good morning. How are you?
Good morning. How are you? Thanks for coming to me. I'm a little lonely out here all by myself. When I first came to Ohio State for my fellowship in '99, our treatment of choice for gastroparesis was laparoscopic pyloroplasty and G-tube placement. So we did quite a bit of those. And over the years, that's sort of been abandoned because although they did pretty well short term, they just didn't do very well long term, and we haven't done that very much. So just a little bit skeptical about sort of the long-term data for how these patients do after any type of pyloroplasty. And in the bariatric, just anecdotally in the bariatric population, I found that the patients that come for bariatric surgery but also have gastroparesis actually do fairly well. But the patients that come for bariatric surgery because they have gastroparesis and want that fixed haven't done as well, and the pain seems to be the thing that's probably the largest headache for us to manage afterwards. And just anecdotally also, for those patients, I'll use enteral access, like a tube in their remnant, just to kind of help diagnose the fact that if I did a remnant gastrectomy, that would help them. So if they decompress with that G-tube and feel better, I'm much more inclined to then offer them a remnant gastrectomy. So we do have surgeons here. Dr. Perry probably does the most, but also Dr. Mira and Narula do a lot of POEMs. They're actually very excited about doing a pyloromyotomy. They just haven't done one yet. And So I got to guess find them the right patients to do those cases for. But it was a great talk today. Thank you. I think it's really important that we talk about this and try to find the right algorithm for treating these patients. So thank you very much.
Thank you.
All right, thanks, Brad, for your comments. Let's go to Geisinger Clinic in Pennsylvania. And I think I saw my friend Tony Petrick. Maybe he has left the room already. Do you guys have any comments from Geisinger?
This is John Gabrielson. Tony and I are partners. We just had a meeting on this actually last Friday, and we're getting ready to start doing the G-foam or the pop. And so it's just a question of trying to put together the multidisciplinary component to it, choose the people appropriately. Something that we're in the discussions about, but really excited to get going with it. So all those questions about training and all that, totally appropriate. Appreciate everything everybody said.
Great. Speaking of training, is it time to start putting on courses, John, and training other surgeons, or do you think you need a little more time to get some results under your belt? Or?
Well, I think, my biggest concern with doing that is something similar to what's happened with the pacer, right? And I think that the difficulty with this patient population is not the technical aspect of doing a procedure. I'm pretty sure anybody can master a pop, especially if they have previous experience with POEM. And the data so far has been, fairly compelling. In my mind, what I like about this versus a pacer is that I feel like we're not burning any bridges. So if symptoms recur, we're back to square one. Every option is going to be still on the table. But my concern, and I've seen this a lot with pacers, is that surgeons go out there, they get trained by Medtronic to do it, and then you have all these patients, floating around that had these things put in, and nobody's following them, nobody knows what to do with them. I've had a bunch of patients come here that had pacers years ago, and the pacer was never turned on. So it's, that's, I think, in my mind, the difficulty when you treat these patients, that you have to make sure that you have a system in place that's going to give them the support they need.
So again, the multidisciplinary long-term care model for this pop, because it's a chronic disease, right?
Right. It's a chronic disease, and this is not going to cure them. And I agree with Brad about, we don't have any long-term data. But if you look at the long-term data for gastric stimulators, it's really not that great either. So and you have to go take them out.
Yeah. So very good. Okay. In closing, let's just we'll finish where we started with our colleagues at Anne Arundel, and see if there's any final comments from our group there at Anne Arundel. I see Dr. Park has left the room, but any other comments or questions?
So, Alex Gans, again, can you hear me well?
Yes.
So just a comment, I have a patient, status post gastric sleeve, who had a paresophageal hernia in the post-op that was repaired, and 6 months later he returns with the sleeve at 3 size enlarged, and with a positive gastric emptying test. Therefore, he has a severe gastroparesis now with a severe reflux disease, obviously. So I would like to know, with this given scenario, what would be your approach? I believe that his symptoms are related to severe gastroparesis that resulted of significant distension of the gastric sleeve. Obviously, there's no hiatal hernia there, but the question is whether should I go straight to gastric bypass, re-sleeve, and laparoscopic pyroplasty, or other alternatives.
So, thanks for the question. That's a very good question because I think we all see patients like that, and I think in my mind, and I'm sure you've done that already, is to rule out it's not a mechanical problem, right? So if you're sure it's not a mechanical problem with the sleeve or a hernia recurrence and some sort of volvulization in the chest, then if the patient is failing, I think you have to make sure that it's not a more complex global dysmotility problem. But a pop is a perfect approach, and I've done a few after sleeve, and it actually makes it much easier because you have a very tubular stomach, so you're not struggling with the scope going into retroflex position as you're trying to do these. And again, I think the morbidity of something like this compared to having to go straight to converting it to a bypass may be worth a try. So I've done a few after sleeve. Technically, it makes it almost easier to do. I can't tell you what the long-term data is because I just don't have it quite yet. But so far, I've seen about half of the patients get better, and I've only done about, maybe 5 or 6 times, and I still have 1 or 2 that are still kind of struggling around, and I suspect they have global dysmotility.
Thank you.
Great. Well, John, thanks so much. That was really fantastic, especially this new innovative approach. And this is, folks, what Innovations in Surgery is all about, is bringing to you new innovative solutions to very complex, challenging problems. I think gastroparesis definitely fits into that category for sure. So again, John, thanks so much for doing that.